Okay, once again, we welcome Dr. Jack Gossard in Boulder, Colorado to our Monday chair yoga class. Jack, take it away.
Do I hit continue here now to be on the, there's a little sign that says continue. The meeting is being.
Yep.
Hit continue.
Okay. You're good to go.
Okay.
Perfect. Thank you, Jack.
All right. Well, I think in organizing this, I thought probably nothing I say or show you will cure ailments that you have, but my intention would be to give you maybe a medical background and information so that when you look up information, for example, on YouTube videos and things like that, that you'll have maybe a better understanding. I am guessing that Julie probably will give you as good or better stretching exercises, strengthening exercises than anything I say or you will see on the YouTubes. Anyway, I looked over your interest, and you have piriformis syndrome first and some other things, and I thought it would be worthwhile to talk about 4 different situations: piriformis syndrome, herniated disc in the low back, hip bursitis, and hip arthritis. And so I'm going to start out. I'm going to speak off pictures that I made. If I hold a picture up to the screen, can you tell me, I hope, that you will be able to see it okay? Are you able to see that?
Not the whole thing.
Lift it up a little bit, Jack. Yeah, there you go. That's better.
Are you able to see that now?
That's good.
That's good.
All right, okay. This is a picture looking at the back of the right hip as you would look at this. And it shows the pelvis, and the sacrum is right here. Here's the piriformis muscle, which goes from the sacrum. It crosses, it's like a pyramid, and it attaches on the tip of the greater trochanter of the hip bone here.
Oh, wow.
Now, the crux of the piriformis syndrome is that it lays behind the sciatic nerve, which goes down the back of the thigh and leg down to the foot. And you can see that if this muscle exerted pressure on the nerve, the sciatic nerve, that you would probably have tenderness right in the buttock area there. And you would also have pain, which went down the back of the thigh and to a varying degree, maybe as far as the leg, but most commonly, I think that doesn't cause pain, which goes down all the way down to the foot, for example. It causes local discomfort there. I will say one other thing too. If I were to take maybe I'll hold it back here, the thigh bone and twist it out this way, in other words, I would be internally rotating it, it would cause the muscle to stretch out more and to put more tension on the piriformis, or on the sciatic nerve. So the symptoms of this would be usually pain and tenderness right in the sort of the meaty part of the buttock that you feel. And the pain might possibly go down the thigh to a certain degree. These usually are intermittent problems. I think I might have had it when I was younger, one time when I was doing a fair amount of driving and had a billfold in my hip pocket, and it bothered me so much I finally had to take the billfold out. I think it was putting pressure on this area. Other things that can cause it, I think, are repetitive activities, maybe a lot of walking, climbing stairs, bicycling, things like that. When the doctor would do an examination, he would feel some tenderness in this area, in the buttock. And also, he would lay the person on the back, lift the right leg, holding the knee straight up in the air, and then internally twisting the thigh, the leg, so as to cause more tension on the muscle and cause the pain that you would have with this syndrome. Vice versa, if he would then roll the leg out the other direction, in other words, roll it like this, the muscle would shorten up and it would take the pressure off the nerve. And the pain that you felt with the internal rotation should hopefully be relieved by the external rotation. And as far as the treatment for this is concerned, I guess stretching exercises are good, which would be sort of the internal rotation stretch that you would put on these in a gentle way to stretch the muscle out. Massage, I guess, is good. This is what's called making a diagnosis of this is a diagnosis of exclusion. In other words, it's saying it's not a herniated disc, it's not bursitis, it's not this, it sort of fits where it is, and so that's what it is. There aren't any x-ray tests, for example, that would show that this is what it is. I guess the only way you could really sort of be sure would be if you could stick a needle right into that area where the nerve is and inject numbing medicine and all the pain went away, you'd say, yeah, that's it, but that would be pretty impractical. I've told you about this Dr. Nabil Ibrahim. It's Nabil-Ebrehim. He has a lot of good videos. He has a significant accent, but he's got a lot of good videos on all sorts of orthopedic and musculoskeletal type problems. And this is one I know. Let me go. So I've talked about that. Let me go ahead with the next one that we've got to differentiate from, and that is a herniated disc in the low back. This is a picture of, can you see it all right? Okay, a picture of a herniated disc. This is the disc in the back, and there's on this first image, it's a small herniation, which presses mildly against the nerve, and that might be enough to send pain into the buttock area. The second picture shows a more significant disc, which puts more pressure on the nerve and would cause pain down the back of the thigh and into the calf. And the third picture shows a really large herniated disc, which is pushing against a nerve and causes pain to go all the way down the buttock, thigh, calf, and all the way to the foot. Now, a herniated disc it comes in different levels. In the lumbar spine, there are 5 lumbar vertebrae in the lumbar spine. Up in the thoracic, there are 12 vertebrae for the 12 ribs we have. And in the neck, we happen to have 7 cervical vertebrae. In the low back, the common disc herniations are at the very bottom disc. We call that L5-S1. At the next disc level up, which is called the space between L4 and L5. And then rather uncommonly, the third place to have a herniation is at the next disc level up, L3-L4. In each of these spaces, a certain nerve is compressed that can be determined on examination. For example, if there's a herniation at the very bottom disc level, that's L5-S1, that typically pushes on what's called the first sacral nerve. That's a nerve that goes all the way down the back of the leg to the gastrocnemius of calf muscles. And so when you check their reflexes, the ankle reflex on that side would not work. There would be some numbness or decreased sensation over the outer part of the foot, and a straight leg raising test where the doctor would lift the leg up and then flex or extend the ankle, push the ankle up. It would put a lot of tension and would cause a lot of pain down the leg. The next level up is the L5 nerve root would be affected, and that would cause a foot drop. And the next level up, which would be the L4 nerve, would cause an absent knee reflex. And so a doctor can determine if it is a herniated disc where the problem is most likely located. And of course, an MRI would tell for sure that that would be a herniated disc. But commonly, a herniated disc like this causes pain that goes all the way down the leg, whereas the piriformis syndrome usually just causes local pain in the buttock and maybe down the thigh just a little bit. The next picture I have is this is a posture picture, all right? It shows how the posture is developed in a human being. This is a baby that's in the uterus, and you can imagine the spine is totally curved this way. When the baby's born, and after a few months, it begins to lift its head up. These other curves are the same as the first one, but now the muscles on the back of the neck raise the neck up so the baby can begin to look around. The next thing is the baby begins to raise up on the hands, and the curvature of the low part of the back now it comes to a curve in this direction. There's a strong muscle that goes from the front of the spine down to the thigh. It's called the iliopsoas, and it also begins to act to pull the lumbar curve in such a direction as this. Finally, here is the standing position, and we have three curves. This is the lumbar lordosis here in this direction. It's the hollow in your low back. And then the thoracic kyphos is the other direction, and finally the neck has a cervical lordosis as the lumbar is. There's some strong muscles which maintain this position. The iliopsoas tends to pull the low back this direction. The muscles on the back of the spine also tend to pull that. They are counteracted by the abdominal muscles in front, but those tend to be weak. And if we want to develop better posture, we have to strengthen those muscles. This is another posture picture that I like. This again shows the lumbar lordosis, thoracic kyphosis, cervical lordosis. They take off, the low back takes off, the lumbar spine takes off from the sacrum. And you can see that if the sacrum moves this way or this way, it is going to cause a variation proportionately in the size of the lumbar lordosis. This shows the three variations. The black line is a normal posture for standing, with the sacrum in a certain angle that causes that lumbar spine to take off that way. If we tilt our pelvis down so that our belly hangs out in front, the pelvis tips down, and the takeoff of the lumbar spine starts more of a curve than usual. The spine, the head has to be centered over the hips and spine. The bigger the curve in the lumbar area, the bigger the curve in the thoracic area, the bigger the curve in the sacral area. Likewise, if the pelvis tips this way, you can see the curves are diminished. Here's a smaller lumbar curve, smaller thoracic curve, smaller cervical curve. So the crux of the posture of the back begins with what we call the sacral angle takeoff. Now, you can imagine the bigger the curves that there are, the more energy that it takes to hold the spine upright, the more energy you have to take. For example, I've got a cane here. Can you see me okay?
Yes.
If I hold the cane this way, it doesn't take me much energy to hold it straight up. The weight of the cane hasn't increased, but you can imagine the farther over I tilt the cane, the more energy I have to use to maintain the cane in that position. Does that make sense? Okay. Now, if we talk about posture, this is bad posture. My pelvis is tilted forward like this. The takeoff angle at the sacrum is such that the lumbar curve starts out in the big direction, and proportionally the other curves follow along to keep my center of gravity in the proper place. And that's when you're, for example, you would be overweight and your belly hangs out. And when this happens, there is more pressure put on the back of the spine, the little joints, and taken away from the front weight-bearing part of the spine. Good posture, on the other hand, is like this, where I'm exaggerating. You know, it's like when your mother tells you, straighten up, pull your stomach in, pull your shoulders back, and your chest out and your chin in. Now, so this decreases the lumbar curve and the curves up above, and theoretically, at least, ought to decrease the energy you have to use to hold that position. Now, you can't walk around all day like this. You'd use up all your time worrying about your posture. So let me see where I am on my slides here. I hope this isn't too confusing. This is a picture of a unit. The weight, there's a front unit and a back unit, and the spinal cord and nerves come down the back. This front part is supposed to bear the weight. The back part has the little joints which guide our lumbar spine in motion. These joints are aligned straight like this, so that the only way the low back can move, the lumbar spine, is in flexion and extension. It really can't move like this. In the upper part of the thoracic spine, the joints are like this, and so when we turn like this, the turning motion is coming from our thoracic area. But the lumbar spine is like this. Now, this picture that I showed you, you can imagine the greater the lumbar curve, the more the weight is then put on these little joints in the back where it shouldn't be. So everything is telling us so far, improve our posture, pull our stomach in, make that lumbar spine straight, as straight as we can. That gets to an exercise. It's a pretty simple exercise. I call it an abdominal crunch exercise. And the way I like to do it, it's designed to strengthen the abdominal muscles. It's the abdominal muscles, which they go from the bottom of the rib cage down to the front of the pelvis, which when they contract and tighten up, it holds your stomach in, it pulls your pelvis up like this, and then your back straightens up. The way I like to do these, I don't know if you can see this or not.
Don't think you can.
You don't think you can?
I don't know.
Yeah, maybe. How's that? Can you see me now?
Perfect.
Okay.
Yes.
I like to do it. Now you always put your knees up like this because that pulls your pelvis this way, so it makes your low back flat. And I simply do this. You first make a motion so as to make your low back push down against the floor. And then I simply do this. I just come up like this, tighten the muscles up. I couldn't possibly get up all the way. Maybe I could have when I was 12 years old. I just hold it for a second or two, break down, relax, like this, and relax. 10 in a row. An easy way to do this is to do the exercise. For example, at night when you get in bed, do 10 reps. And then in the morning, before you get out of bed, do 10 reps. And that'd be it. And the idea is that during the day as you're moving around, these stomach muscles hold the posture properly and hold your back that way so as to reduce this strain on your low back. Let's see here. Let me go ahead. Here's a stretching exercise. You can imagine that it's a matter of pulling your knees up to your chest and and rocking your low back so as to straighten it out. Yeah, let's go on to, there's a question about hip bursitis. Hip bursitis is usually felt over the point of the hip here. You can feel this bony prominence. That's the outer aspect of the hip that you saw before. And the hip muscles go over the this point and cause some irritation and tenderness, especially if you happen to lay on this side at night in bed. Usually the treatment for this is stop doing those activities which aggravate the pain. And I think there probably are some strengthening exercises for the hips and motion exercises to try to get over this. Occasionally, if it's really bad, a doctor might inject that bursal area. It's a little potential space with cortisone. That's if it's really a nuisance. And then let's see. I think maybe there was a question about the tensor fascia lata. And this is and you can pull this up on the internet, I'm sure too. It is mainly a fibrous band which goes down from the front of the pelvic crest here. It goes down, actually it goes down over the point of the lateral point of the hip to cause bursitis pain. And it inserts down below the knee. Someone asked about a stretching exercise. One stretching exercise can be if you stand at a chair, and if you're going to stretch this tensor fascia lata, which would go from the front of the pelvis down the outside of the thigh. I think the exercise is to put the other foot over the other foot in front of the left foot, and then bend the trunk this way. You can see when you give it this motion and the pelvis drops down, it stretches this whole tensor fascia lata down. So this is an easy exercise. You might be able to look this up on the internet as well. One last thing about how are we doing on time? We're getting close, huh?
Well, let's if it's okay with you, Jack, let's keep going. And if people have to leave,
Sure.
we understand. But let's keep going for a few more minutes at least.
Let me talk about hip arthritis. And arthritis in general, very basically what it is loss of the cartilage, slippery joint surface on both sides of the joint, and so you get bone on bone. As far as the hip is concerned, the pain from a hip arthritis usually is in the front of the hip in this direction. Sometimes it goes down in the groin and down in the front of the thigh, and that is hip arthritis pain. Bursitis pain is pain and tenderness out here. And a person with arthritis, for example, in this right hip, if I had arthritis in the right hip, you see people walking along like this. It's because what they do is they try to, the hip is painful. They will do motions so as to decrease the pain that they're having from arthritis in the hip. And so what they are doing when they walk like this, they are putting the weight directly over, they are centering the weight over the hip. So there's not as much pressure on the hip. The hip, you might think of the hip joint as being a lever arm. Here's one hip, for example, on this end, and there's another hip on joint on this end of the pelvis. Now, let's say we're bearing weight on the right hip. When I bear weight on my right hip, you would think, gee, if you put weight on the hip, your pelvis is going to sag down like that. In other words, I would walk like this. What is it that keeps the pelvis level? When we walk, the pelvis stays level as we're bearing weight, for example, on my right leg. The pelvis stays like this. And you can see if this is the hip joint and this is the pelvis, it's the muscles that go from this point here down to the outer aspect of the hip. I'm going to exaggerate now. When I put weight on my right leg, my right hip, these muscles grab hold and maintain this pelvis level, you see? Does that make sense? It's these big muscles out here. It's the hip abductor muscles, the gluteus medius and the gluteus maximus, that when we put weight on the right leg, those muscles grab hold and maintain the pelvis in a level position. One way you can see to decrease that, and then there's a fair amount of weight and pressure you see on the hip, because not only does the hip have to take the weight of the body that's above it, it has to take the leverage, the lever arm that's pointed wants to pull the pelvis down this way, and the muscle leverage, it has to pull the hip up this way, so that if there's 100 pounds above the hip joint, there would be considerably more pressure than 100 pounds on the hip joint because of the leverage pulling down on this lever arm. And so there was many years ago, there was a popular article by a doctor in Milwaukee, and the title was "Don't Throw Away the Cane." As you look, as I'm bearing weight, when I've got a cane and I put the cane out here, and I put weight on the right foot. So for a right hip arthritis, you would use the cane in the left hand. You see what it does? It decreases the lever arm of the pelvis body weight that's going down that way. And therefore the tension that the hip abductor muscles must hold to maintain the pelvis level will be less. And so a person with arthritis that would walk like that, if they use a cane, they can walk in a with a better gait. Well, of course, they got total hip replacements now. Well, let's see. I think I've pretty well covered everything. Mary Jo apparently had a question about arthritis in the shoulder. Again, if it's arthritis, it'll be a wearing away of the joint surface, and it's a matter of getting along with it with gentle exercises and being careful with what you do. And now these days they've got a total shoulder joint if it's a terrible bother, but that's an elective procedure. Anyway. Any questions?
Jack, that was fantastic, Jack. I mean, we're so fortunate to have your knowledge and experience about so many things. Somebody asked in the chat, is it okay to sleep on your back?
I think so. If it doesn't hurt, yes. I guess it is.
Yeah, and Eileen, I don't know if you're still here, if you want to add any other like background information about what risk you think that might be causing, or if you want to chime in with any other follow-on.
Yeah, thank you so much. I really appreciated your presentation. I was just curious. I like to sleep on my back, and I was wondering, is that good for your bones to keep them all straight?
I think it probably would be. I think it would be. Your hips would be out straight that way. I guess it would. Yeah.
Okay.
I want to tell you one thing that I used to do. There's a treatment. I'm getting back to the posture of the bad posture of the lumbar spine being the much of the problem of our low back problems. And years ago, we were taught in my residency how to put on what's called a flexion body cast. And the way we put these things on, we put it on with plaster. Of course, we put felt padding on, and we would have the person hold on to something like this and bend forward so that they pulled their stomach in and their low back was pushed out the other direction. And while they were in this position, we would quick put a cast on, And the cast would come up higher in back, on the back, and it come down lower on the buttocks, not quite low enough that they couldn't sit. They could sit, and the cast would be up just above that level. But as it came around the front, we would just put it sort of in a narrow band across their stomach, and while they were holding this position, we would sort of mold the cast in this way in the stomach. So it had a 3-point fixation of holding back here, pushing in here, and pushing the upper part of the back this way. So when they walked, they sort of walked, they walked around like a turtle like this. People leave these on for about 4 weeks. And I know when I was in at the Indian Hospital in Gallup, one of the patients came in, a man, and he's very overweight, big belly, and had chronic low back troubles. And I thought, well, I'm going to put a flexion body cast on him. He was big enough. I had to put a sort of a gown on and get underneath him to support his belly to push it up as the cast set up. It was made out of fiberglass, and I thought, well, I'll be interested to see how this is done. Typically, we'd have them come back in 4 weeks, and well, I was curious to know how this worked out. And while they would be in the cast, they would also work on those little exercises in bed, which would be easy to do because they were already in a position to do the exercise. We came back in 4 weeks, no cast. And I said, what happened? He says, I got tired of it after a day and cut it off. And I'm thinking, stupid me, I should have cut it down the side when I first put it on so that he could get it in and out of it. Anyway, that's a little aside.
Jack, I can't imagine. Thank you for sharing that. We had another question about when is it appropriate to use heat or ice?
Boy, I think I'd almost refer these questions to a physical therapist. But
You're right.
I guess, gee, I don't know. I haven't thought about that a long time. I'm thinking if it's an acute injury, it might be better to use heat, and if it's something of a chronic nature, use ice. And if it's something of a chronic nature, perhaps use heat. But it might be a personal preference as to what seemed to work better.
Is it true that the icing can reduce inflammation if there's swelling, so that you would maybe do that initially, and then later maybe alternate heat and ice? I mean, that's a little bit of the rationale that I've heard, but I don't know. And also some people find it so uncomfortable to ice,
right?
Whereas the heat can feel a little more soothing. But I don't know if there's a best practice.
I really don't know, but it makes sense after athletic injury. Someone has a sprained ankle, while they elevate it and put ice on it and like a compression wrap. That makes sense that after an acute injury, it might be better to use ice to decrease the blood flow and momentarily anyway. So that sounds right to me. Yes.
Eileen, go ahead.
Yeah. I'm going to ask you just a question. I don't know so the question is, sometimes in the mornings I get a tingling in my hand, one side of my body when I get up, and then I kind of move around a little bit and it goes away. Would that be a herniated disc, or would that be, I don't know, it would be hard for you to probably comment.
Yeah. You mean you have a tingle in your hand?
Right. Yeah. And I like to sleep on my hands. And so then I get up and then I have to kind of move my hands around and it goes away.
Yes. It sounds like it's a local kind of a problem where pressure is being applied to a nerve, which causes the nerve to go to sleep momentarily, and then it takes 2 or 3 minutes to fully wake up. Is that what happens?
Yeah, but then sometimes during the day, I will get a kind of a sensation, not pain, just kind of a pins and needles kind of thing.
Mm-hmm. If you move your head back and forth and all around, does that affect it at all?
No. Mm-mm. I don't want to put you on the spot, but I was just
Right, right.
curious. Yeah.
I don't think it's a herniated disc though.
Okay.
I don't think it's a herniated disc problem. Herniated disc are more uncommon in we older people.
Mhm.
Herniated disc, like in the lumbar spine, they're more common in younger people. Well, we'll say 30 to 50
Huh.
age. So, and by the time we get older, our backs are pretty well sort of set, so to speak. Not that they can't be improved, but their things are beginning to calcify to a degree, I guess.
Right. Thank you.
Sure.
Do we have time for one? Does anyone else have a question they want to ask Dr. Gossard before we move on?
Julie?
Yeah, Debbie, go ahead.
Yeah, when you were talking, I can't remember now, it's the Proform, whatever that was at the beginning that you were talking about. I thought like a combination of bursitis in the hip that affected the IT band. I mean, the IT band was so tight.
Mhm.
And so a lot of the treatment I had took a long time. But eventually somebody finally came up with using this enormous metal plate and actually pressing on that IT band. And for some reason that worked. I had gone through so many different kinds of treatment, and that seemed like a crazy one, but it actually worked.
Wow. So it was a matter of putting that or the metal plate against the outer side of your thigh. Is that it?
Down the side of my thigh, down to my knee, between my
Yes.
hip and my knee. Yeah.
Right.
With a lot of pressure on it. And it hurt like crazy when it was being done, but when it wasn't being done, there was no pain. There was no after effect to it.
Yes.
Except that over time, that just did loosen up that band.
Wow. Do you think it was a matter of stretching the IT band?
Yeah, I
Is that what
think,
the therapist said?
yeah, but it was hard to stretch it enough, to loosen up that whole area. I went through all kinds of attempts.
Yeah. I did happen to look up a couple exercises to stretch the IT band. One of them was one I demonstrated where you have for example, a chair here, and if you're going to stretch this IT band, which makes sense, it goes from the outer side of the pelvis straight down the thigh to the sort of the front of the knee a little bit. And if it makes sense if you would give it this action where your pelvis drops down and you push over this way, why it looks, and as long as you keep your body straight from the thigh up through the trunk. In other words, if you bend over, that's sort of cheating. If you do this, it looks to me like that would stretch that IT band out. And that was one that they gave. Like, now you have to keep this front knee bent to allow the pelvis to drop down while you're straight up and down this way. And it looks to me like that would put a stretch on.
Yeah,
There's another one, I think. Go ahead.
sometimes they use, I think that, kind of similar to the feeling of a metal plate like that is a foam roller, which a lot of people like to use. And it hurts like crazy on your IT band.
Yes. When you had that pain with the IT band, where was the tenderness? Where was the pain felt?
It was like, my hip hurt.
Yes.
But even if I touched the side of my leg going down that band, just touching it hurt it.
Yeah.
It was really tight.
Right. Yeah.
But by the way, I just wanted to thank you too. I think your illustrations were the best I've ever seen in kind of showing, how things look in there. Yeah.
Those came from a book that was, I think, written about 1962. It was written by I guess you'd call him today a physiatrist or a physical medicine doctor. That's what he was back in those days. And they had to resort more to physical measures and common everyday kind of things rather than, for example, an operation. And
You know, the other condition that people our age seem to have a lot is stenosis.
oh, spinal stenosis. I didn't mention that. I was, I guess, a bit negligent, but what that is, and typically that does happen in older people. It's rather uncommon young, but the older we get, and what happens with the degeneration of the spine, which occurs with age, wear and tear, and weight bearing, and all that. The structures that surround the nerves in the spinal column, down towards in the very low part of the back, they begin to, those structures of fibrous tissue and maybe bony spurs begin to enclose around the nerves. And when they enclose around the nerves, typically they cause pain, which goes down, starts in the back and goes down the buttocks and usually down both legs, down both thighs. And it typically happens, the pain of spinal stenosis comes on when a person gets out of bed or out of a chair, they stand up. When you stand up, your thighs go down straight. That the big iliopsoas muscle we talked about tends to pull your low back into a more lordosis, and it puts more pressure. Then that position puts more pressure on those on the spinal column and the nerves in there. And a person will develop pain which goes down the leg after they've walked for a little bit of time. Typically, at least in the beginning, when they sit down then, and their back assumes that flatter position, the pressure on those nerves is decreased and the pain tends to go away. They call it pseudo-claudication. Claudication in the legs usually is from an arterial problem where the aorta and the main arteries to the legs are compromised by arteriosclerosis, and there's not very good blood flow. And when a person walks, they begin to use energy in their muscles, and then they develop pain in their muscles. And if they stop walking, that pain goes away. That's called claudication. Pseudoclaudication is pain which comes from the inside the spine because of the enclosure around the nerves, and it comes from walking. But that is caused mainly by the position of the low back, which is more has more of a curve in it, and it presses up, and sitting down will resolve that to a degree. But those are usually tackled by neurosurgeons when they really get bad, and typically they do pretty well. I know my aunt, no longer living, but she had significant problems with spinal stenosis, and some neurosurgeon did an operation and basically removed the bony pressure that goes on the nerves, and she got a very good result from it. Thanks for bringing that up.
Thank you.
That's so interesting. Thank you for sharing that. We have time maybe for one more question or query. Anything? Any comments anyone wants to share?
Thanks so much. That was really informative and helpful.
Okay, well, thank you. I enjoyed it.
And
Yeah, I really appreciate it. Thank you so much.
You're welcome.
so you recommend, I'm sure, just a lot of exercise and something like yoga that, keeps your body flexible.
Oh, I think so.
Yoga's
I think the
great.
very last comment I made is moderate activity for us types within reason, and gentle exercise, and try to stay active. I think activity can't be beat.
Mhm.
Jack, I have a quick question regarding building core strength while sitting in a chair, because I want to make sure that if I offer an exercise to our students that we're kind of targeting the right muscle groups similar to what you shared on your back. So I've done these in class before, but I'm wondering if you think I'm targeting the right muscles. There's two kinds of what I call chair sit-ups, where you can lean back in the chair and then, engage your lower abdominals to come up. You can also come down and lift. And, it may not be the same kind of exertion that you get given your body weight when you're on your back versus seated. But do you think there's benefit in doing a lean back, lift up, a forward pull up, or any other thing that comes to mind just intuitively for you that can be done in the chair during class to help build core strength? We also sometimes focus on what I call, I'm trying to target oblique muscles, the side of your abdominal where you're leaning and lifting.
Right.
It's less of a stretch, but you're pulling up. Do you recommend, or even if you haven't done those before, do they make sense for the muscle groups that you suggested we strengthen?
I think it does make sense. One thing I would say, when abdominal exercises are done, you don't want to do them with your back, your lumbar spine in a big curve like this. That's sort of counterproductive, you see. Those abdominal exercises ought to be done with the starting point of the low back being flat, because that puts the abdominal muscles in mechanical advantage to easily tighten up then. Whereas if there's a big hollow in the back and you try to, for example, if you go back too far and then in getting up, if your back is not flat, it's good if it is flat. But if it has a big hollow in it, you can see that there's going to be strain which shouldn't be there. So yeah, whether it's done back or forward, I think the position that the abdominals tighten in ought to be such that the back is already in sort of a flattened position.
Curving forward.
Yeah, sort of curving forward.
Curving and
Yeah,
pressing, maybe if you're in the chair, pressing your sort of lower back and hips into the chair so
That's
that you
right.
can
That's
anchor there, and then
Yes.
you're using your abdominal muscles rather than your back muscles.
Right.
Okay, thank you for sharing that. I'm going to add some more of those into our weekly class routine. I do a lot of core work in typical yoga class when we're on our backs on the floor. It's really critical, or even like plank exercises when you're on your palms or your forearms are really, really good for the core, but we can't do those in a chair.
Right.
You have, so I'll look for more things that we can do to build core strength, given how important it is for your back, all movements that we take. So thank you for emphasizing that.
Right.
Okay. Right.
All right. Well, we so appreciate you, and yeah, it's so wonderful to have you. And I'm glad that we recorded so we can share with those who weren't able to join us today. I'm going to stop the recording now, unless anyone else has any final thoughts, comments, or questions.
I just have one quick question. It's hard for me now to get down on the floor to do all these exercises. Do you get the same benefit if you do them in bed, which actually really has, like a soft mattress?
Sure. Yeah. As far as those abdominal crunch exercises, yeah, I think those are fine to do in bed. Others, I guess, I'm not sure. If you would do exercises laying on your stomach prone, I'm not sure if that would be good.
No, I don't do any of those anyway.
Yeah, right. But I think the crux of it is when you do those abdominal strengthening exercises, put your low back in that flat position, away from that big curve that it's got.
Yeah.
Yes.
Yeah. Thanks again. We really appreciate your coming. And thanks, Julie.
Thank you,
Okay.
Julie.
Thank you.
Thank you.
Yeah, thank you, everyone. I'm going to stop the recording. Jack, you're the best.